this very stimulating discussion and friendly debate, so there won't be any blood, okay? About our current mental health system entitled Do No Harm. Do our mental health practices alleviate or contribute to human distress? We have some amazing two great thought leaders in this field who are not afraid of being ostracized, Dr. Jeff Ball and Dr. Andrew Gerber. Dr. Jeff Ball, for those of you who are from PCH, know he is the founder of PCH. I'll go into his bio a little later. And Dr. Andrew Gerber from Silver Hill. Before we get started, I want to give either, I think, Sally or Kara a minute to discuss an overview of Silver Hill. So I'll pass it over to them.
Great. Thank you so much, Dr. Westby Trent. I'm Kara Pate, and this is Sally Sebastian. We are part of the clinical outreach team at Silver Hill Hospital, and we are so grateful for all of you to join us today. Just a little overview of Silver Hill Hospital. Silver Hill Hospital is one of the oldest not-for-profit freestanding psychiatric hospitals in the nation. For the past 90 years, we've served really clinically complex individuals, adolescents and adults, all genders. And we have three distinct levels of care. We have our inpatient hospital, where we serve adolescents and adults who are in need of psychiatric stabilization. And then we're also able to detox individuals 18 and older there. We have 7 residential programs, which we refer to here as our transitional living programs. We have 3 DBT adherent homes. One of those is for primary substance use disorder. We have an adolescent DBT adherent program. We have a program for executives and professionals that we've created in partnership with Yale University. We also have a program for individuals with long-term chronic neuropsychiatric illnesses. And then our newest program is our 12-day intensive assessment program, where our goals are to provide our patients with diagnostic clarity and treatment recommendations after they've spent the 12 days with us. We have 16 full-time psychiatrists on staff. We have 24-hour doctor and nursing staff here on campus 7 days a week. And then we also offer a full continuum of IOP services and aftercare support. So if anybody has any questions on Silver Hill, we'd love to talk to you. We'd love to meet with you. You're welcome to reach out to anybody on our business development team. So thank you. And we'll turn it back over to you, Dr. Westby Trent.
Thank you. And so for those of you who don't know PCH, PCH is in sunny California. We actually offer PHP, partial hospitalization, and IOP level of care. We actually have supportive housing. We have about 4 of them in Los Angeles area for issues around problems in living. And so we can have clients that live in our homes while they get out of their beds and actually come into a treatment office to do treatment. We're trying to simulate real world and for them to get up and get into work. The homes, we have 1 all female, 1 all gender, and 1 all male. And then we also have a transition home for those clients who need to develop their activities of daily living and need some support around that. We just recently also added an independent community living home that has only 2 beds. And for those clients who need the support around the community activities or being with others, but can actually deal with all of their activities of daily living while they're coming into treatment. Our Pasadena location is for more acute issues, such as people who might be having active hypomanic symptoms or maybe hearing voices and would not be able to participate in the intensity of the PHP or IOP program here. Our most recent program that we added is One-to-One by PCH, whoop, whoop, with Ray Santa Maria. I believe he's also here. And that program offers IOP level of care all on an individual basis for those individuals who may not be able to leave their lives to attend an organized, structured 9 to 5:30 program, or for those individuals who just need, their nervous system is just so sensitive that they really need all treatment done on an individual basis. So that's kind of us in a nutshell. You'll have some time at the end to ask questions both about Silver Hill or PCH if that is what you have in terms of questions. Okay, I think I did that real quick. Now, so my job actually during this time is really to kind of hook these gentlemen and reel them back in when they go too far off out into the deep, because they actually can talk about this topic that we're going to talk about for days. They've done that before, and so Amanda has asked me to be their, what's the word? The moderator. That's the nice way. They're the moderator. For those of you who are here and you want CE credit, please remain for the entirety of the program. And you will then receive, if you have not already, an evaluation, so that we need that. You will submit that back to ce@pchtreatment.com. That information will be put in the chat. And then you'll be receiving your CE certificate by Monday. Okay. We'll have about an hour of discussion, and thereafter we will open it up for questions. If you have a question while the presentation is occurring, you're welcome to go ahead and put it in the chat. I just won't respond or read it until we are done with the hour of the friendly debate. Okay, let's see here. Let me introduce, I need my glasses for this part. Read the bio of our legends who are here. So legend number one. Dr. Jeff Ball, a native of Los Angeles, received his BA summa cum laude and Phi Beta Kappa from UCLA. Here, he earned his PhD in clinical psychology and completed research on both projective processes in marital relationships and an integrative treatment model of bipolar disorder. Dr. Ball was a psychologist at the West Los Angeles Veterans Administration Hospital, and he worked for many years in private clinical practice. Dr. Ball has been on the UCLA faculty in the Simmel Institute for Neuroscience and Human Behavior as an assistant clinical professor for many years. In his role as CEO of PCH Center, Dr. Ball supervises, teaches, and consults at PCH. He presents his model and vision for mental health, both within the center as well as in the clinical and academic communities, as well as on social media. And then he gets a lot of threats. So you left that part out, Jeff. Okay, Dr. Andrew Gerber, MD, PhD, is president and medical director of Silver Hill Hospital, a private non-profit psychiatric hospital in New Canaan, Connecticut. Dr. Gerber is a child and adolescent psychiatrist whose career combines his work as a clinician, scholar, research scientist, and executive. He completed his medical and psychiatric training at Harvard Medical School, Cambridge Hospital, and Cornell and Columbia Medical Schools. He completed his PhD in psychology at University College London and the Anna Freud Center. In his role as president and medical director of Silver Hill Hospital, Dr. Gerber oversees day-to-day operations of inpatient, residential, and outpatient levels of care, as well as all supporting functions, including research and education. He is dedicated to building a continuum of high-quality care for patients and their families using an interdisciplinary and integrative approach, while also identifying new ways to provide innovative treatment to patients regardless of their resources. So welcome these two amazing gentlemen, Dr. Ball and Dr. Gerber. I told them I would call them by their title. They've objected, but I'm going to stick to it. So let's start with Dr. Ball, who will provide an evolution of his thought process and interest in this movement away from the medical model.
Okay, thanks, Adriana. You'll get your bonus soon. Trying to think of how to frame this all. The current models, in an ideal world, we do best clinical practice. Our world is impacted by cultural, political, economic factors, and those tend to take precedent. So when I began my career at UCLA, I kind of grew up in what was really a biopsychosocial model, very DSM based, very pathologizing. I taught abnormal psych for 30 years. And I always had a problem with the title of that course. I mean, abnormal psych implies pathology from the get-go. And I always give the example, when a plane crashes, it's not abnormal physics. When people crash, it's psychology, it's not abnormal. But I think that's the lens that we tend to look through. And it's mainly based largely on a medical model and diagnostic system that see illnesses residing within the person. But I taught about, in abnormal psych, about dopamine theories of schizophrenia, about genetic studies of twin studies, about chemical imbalances. We did a big bipolar research study of family therapy and bipolars in the 90s with a friend of mine, David Miklowitz. And we used to teach about people had this chemical imbalance and the mood stabilizers were leveling them out. And over the years, that's turned out, most of that's been debunked. The dopamine theory has not held up. The chemical imbalance theory has been debunked for years, although you wouldn't know it if you watch all the pharmaceutical ads on television, because they still use that for antidepressants. And so we're going to talk about a lot of these issues. Many of the current narrative is about, they're great marketing tools, but they're not very scientifically based. And as I came to study more of this and just work with people over the years, I learned, the DSM, for example, I believe 97% of the diagnoses have no proven biological or genetic basis. That they're largely decided upon by consensus. And I think, part of the problem is that it's as though, this idea of mental illness lives in a social and political vacuum and just develops these problems just develop in the brain. And it's not only devoid of context, but it's devoid of real scientific backing for many of these disorders that we work with and treat. I'll give, before I go off too much, I'll give a couple of examples of, that our DSM diagnoses are decided by consensus. It's more a political document than a scientific one, that you get committees of mostly white male professionals and mental health professionals who decide what's normal and what isn't. And they will pick out, you have to have 4 of these symptoms or 5 of these for a month. There's nothing scientific behind any of that. I'll give one example. I think the DSM-2 had anxiety and depression were part of the same diagnosis. And when you work with people, you realize no one's anxious without some depression and no one's feeling depressed without some anxiety. There was a committee formed to decide whether to break them into 2 different diagnoses. It was 14 people, 5 voted to break them into 2 diagnoses, 4 voted against, and 4 abstained, or 5 abstained in math. So you basically had 5 out of 14 people deciding these are 2 distinct diagnoses. And now they're part of that kind of Bible of the DSM, and that's how they're treated. An obvious example is, homosexuality was in the DSM until 73 or 74. And they had a vote, basically, after, a lot of protesting. 55% voted to take it out, 45% wanted to leave it in. So again, these things that become kind of reified as these distinct disorders are really are so subjective, and they're not particularly valid most of the time, and they're not real reliable. That's part of my evolution of thinking. I think we're also going to talk about the whole idea of modern day capitalism and how it, from a macro level, it impacts how we do treatment and the way that we look at people. But I'll hand it over to Andrew to expand in whatever way.
Thanks, Jeff.
Thanks, Jeff, and thanks everybody for joining it, and Adriana for hosting today. When you were asking what's the right term, the term that came to my mind is our parent. You're going to make sure that we behave. So it's such a pleasure to talk about these topics, in part because I think there's so much that Jeff and I agree on, and I hope that you hear that through the conversation, that there's some basic principles that actually, it's one of the things that connects us and connects PCH and Silver Hill. But nonetheless, I think these issues are complex, and often I think in our public discussion can get oversimplified in ways that it's actually really worth teasing out in the way that he and I are going to attempt to do today. So to that end, let me sort of start my own narrative around this question of the medical model. And inspired by Jeff, I'm gonna go back even further. I'm gonna start with my childhood. And I'll tell you why. So I grew up in a family where both my parents are physicians, not psychiatrists, both internal medicine. And when people used to ask me as a child what I wanted to be when I grew up, I used to say, not a doctor. And part of that was because I resented the implication that I should be like them. But part of it was because I grew up hearing, I think more so maybe than they wanted me to hear, the hierarchy and the authoritarianism embedded within the medical model in so many ways. And part of that I do think is generational. These were my parents, so of course I saw them as authorities because they were and could decide things for me. But part of it was I saw it in the way they and their colleagues and their friends talked about patients and medicine. And by the way, I think my parents are good doctors and cared about their patients and did good care. But there was a way of thinking about expertise that put the medical world up here, and not just patients, but other professionals down here. And I think even at a young age, I knew that was out of step with where our culture was going, and certainly what I believed personally, that's not the way to help people get better. Now, the counter argument would be, well, when we developed surgery, when we developed antibiotics, that hierarchical system maybe worked out okay. Maybe. I think that would be another discussion. So I'm not going to comment on that, but I will comment on it in mental health, because I think there's no question in my mind that hierarchical system is problematic at best and actually destructive in terms of what it does to our patients. And we think about what it means to patients to be told you have this or you are this, as opposed to being engaged in a mutual relationship with someone who can be a consultant, helpful, think with them, help them understand themselves better. To me, that's where the model of the best way of interacting with individuals who are struggling from one form or another needs to go. And so, I don't think Jeff and I would ever disagree about that. Now, the problem that comes in, though, is, of course, you can't just reset history and expunge the past and that hierarchical medical model. I do think psychiatry has come a long way, and I think the general field of mental health has come a long way. But there's some things you can't undo, and let me say what I mean by that. I think as much as I agree with Jeff that illness is largely a societal and a family construct, and there's lots of good evidence to support this, and I'm sure we could talk about that. There is a way in which, if I'm an individual who's suffering, or if I'm a parent and have a child who's not going to school or suffering in some other ways, I want to know what to do. And when we engage as professionals, we have to address in real time the question of what's wrong, what's going on, how did it get that way, and how do we help make it better? And in some ways, in its most benign form, that's what the medical model attempts to do, right? If I have a pain in my leg and I go to the doctor, I don't want a conversation about how that's socially constructed. I want them to tell me why my leg hurts, how it happened, and what I can do to make it better. And obviously I'm being a little glib and oversimplifying, but to some extent, that's true of our patients, of our clients, of ourselves, when we approach these issues. Now, part of our job, I think, as medical professionals, is health professionals, mental health professionals, is to teach and to say, I understand that that's what you want, and if it was a pain in your leg, I could probably do some degree of that, but this is different. And I do think we have to do it. But as we do it, I think we also have to acknowledge why those other things would be nice if we were able to do them. And I'll give you the technical terms. In medicine or in medical school, they teach you, well, first figure out what the etiology of a disorder is, what caused it, then figure out what the pathophysiology means, what are the mechanisms, and then we're going to look at prognosis and treatment. Sounds really cool, right? If you know those things. It's really important, I think, to recognize that at this stage in the field of mental health, we do not have etiology and we do not have pathophysiology. As much as people do like to say, oh, we know as much as any other field of medicine, we know all these things. We don't know those. The brain is so much more complicated than any other organ system. Do we have ideas about things that make certain individuals more vulnerable to certain illnesses? Yes. Is it useful to talk about them? Absolutely. But do we know what causes an illness? We do not. Do we understand at the level of the brain how these illnesses work? Absolutely not. And anybody who claims otherwise, to be honest, is either misinformed or really misleading you. And to Jeff's point earlier, when I hear well-meaning psychiatrists, neuroscientists, or even non-professionals say it's a brain imbalance, I cringe. Now, I cringe not just because it's wrong, because it is wrong, we don't know that, but I cringe because in their attempt to make it approachable, because most people who call it that are actually trying to be helpful. They're trying to say, don't feel guilty, don't be stigmatized, this is not your fault, it's no different than diabetes. I like all those messages, but if you use the wrong reason, you're going to destroy trust. And I think our field did that in some, back to the hierarchical nature of the way my parents talked about their patients. I think there was an idea, well, we don't have to be totally accurate. We're going to say it because it's a nice thing to say, it's a brain imbalance and so on. I think that was the origin of it. But then this other thing happened, and I want to get to Jeff's last point, and then I'll stop and turn it back to you, Adriana. One of the things that happens in our society over and over again, and I guess I sometimes find it frustrating that we're not, as a field, better at anticipating this, is things get hijacked by the profit motive. It's built into capitalism. You might even say that the people who do it are kind of, quote unquote, doing their jobs, maybe letting them off a little bit lightly, but whether you're in the insurance industry or whether you're in the pharmaceutical industry, and you hear somebody talk about a chemical imbalance, you think, and they did think, oh, that's a good advertising campaign. I can now sell a drug, and I can sell it for a lot of money, and I can give it a fun name, and I can, make up all beautiful posters to show how wonderful it is, and I can profit from it. And of course, the pharmaceutical industry has done that to enormous success in our country. And the insurance industry can say, I'm in the business of having to pay for people's care. I can't pay for everything people ask for because then, I'd never make any profit. Well, I have to come up with ways to basically say, I can't pay for that. So what am I going to do? I'm going to use the language of science. I'm going to hijack some of these ideas that may have originated in well-meaning psychiatrists or research labs or so on, including the DSM, but I'm going to use it for the purpose of essentially rationing or limiting care. And this has happened to a devastating effect in our country. It is the reason, in my opinion, we have such a broken mental health system. So here's the danger now. And I was saying this phrase just the other day to Jeff. We can't throw the baby out with the bathwater. Yes, we have to be extremely vigilant and reject when neuroscience is misused, when the medical model is misused, when all these rationing, all for the profit motive that are not about what's good for patients, right? And at the same time, to me, there is value in still, at times at least, thinking in a scientific way. And I don't mean that all of mental health care should be science. I don't think that. I think there's an enormous amount of art and interpersonal responsiveness that is in many ways as, if not more important than some of our science. But we can't lose the thread of science because science also helps in certain ways. Science keeps us from only dividing into camps where we just defend our identity and we have no way of checking in with each other. Science helps us make advances. And even some of the treatments we have that at times have been misused, like medications and so on, I do believe there is efficacy when used appropriately, and science can help us establish when it's useful and when it's not. So that, to me, is the goal, in a way, is to parse out what do we want to hold on to and what do we really want to reject because it's not in the best interests of our patients.
Thank you, Dr. Gerber. Now, so you're saying that the disease model is dominant in mental health. It sounds what I'm hearing for two reasons, for monetary gains and for ego boosting. Is that, so we have capitalism and our egos.
I mean, listen, if I could just put a slightly different on the ego, I think for reasons of power and hierarchy, right? That people assert their dominance by using, pseudo precision.
Now, if that is the case, and we have all of these young people and senior folks seeking treatment, you mentioned earlier about trust in terms of reestablishing trust. How do we, in this system, how do we reestablish trust as a community and provide appropriate care for folks without doing no harm?
I think, I agree with most of what Andrew said. I think there tends to be in the medical model, though, a focus on illness and it being inside the person. And when I did used to teach about, psychopathology and all this, I would talk about a number of different views. There's a medical view, there's a psychological view, there's a sociological view, there's an anthropological view, there is a spiritual view. And I think when the medical view dominates, it tends to push aside these other views. A good example is, so ADHD has been labeled as a disorder and an illness, basically. My kids had some issues with attention early on. My wife called the pediatrician. She wanted to give them Adderall, which is crystal meth, basically. And also research shows it doesn't improve academic performance at all, but it helps control them. Obviously, I rejected it. I brought a neurofeedback machine home, and it really helped quite a bit. But there's also, Finland has a school system where they have, I think 4 or 5 times as much free time in recess as they do in American schools. And they found very low incidences of what they call ADHD. A Texas school replicated that. I think they doubled or tripled recess time, and the incidence of attentional problems dropped. So I think it's an example of where you have, again, a context of a school system that's not really designed for a lot of kids. And that when you change the environmental contingencies, a lot of the problems go away. So I think part of the problem, and Foucault talked about this back in the 1800s, about the clinical or medical gaze. And at the time, again, it was a well-intended thing, because I think at that point, they didn't really have diagnostic models and all of this. But the clinical gaze was how doctors would modify the patient's story and fit it into a biomedical paradigm and filter out the non-biomedical material. So it's selecting what's considered to be the relevant elements of the data stream that they're getting, but it also basically eliminated the need for doctors to listen to their patient's narrative. And so, I think that the way that we look, as well as the way we categorize people, but also the way that we listen to them and look at them, is very important. When I worked at the VA, medical director called me over. She was doing rounds with the psychiatry residents, and she told me that Mr. So-and-so just threw her out of his room. He won't take his meds. He's swearing at her. So can you go do something? So I went in and talked to him, and he was this about 400-pound former New York stockbroker, who was obese and had horrible sores on his legs. And I said, I heard, you won't take this medication that's being prescribed. Well, that bitch wants to give me this stuff, and it's, caused all these horrible side effects, and I don't want anything from her. And I said, well, she wants to give you something else that may not have those side effects. I'm not taking anything else. And I said, look, you're the one in pain, right? I said, stop cutting off your nose and spite your face and take your fucking medication. He said, fine. So I went back out to her, and she, I said, you can go back in, he'll take it now. And she goes, what did you do? As though I was this miracle worker. And I said, I have a relationship with him. And so he trusted me. In your question of trust, I think it's about really listening to people and trying to understand their problem from a broader perspective of just something, it's that old question of not asking what's wrong with you, but ask what happened to you.
Dr. Gerber, And actually, I'd like you to respond to some of the things that Jeff said, but one of the questions that came to mind as I was listening to Jeff is that we read is, again, who do we trust? Because we also read all these articles. I've read articles. When my child was younger as well, there was issue around potential ADHD. Of course, I rejected medication and he's doing well. He's a level 10 gymnast, all straight A student in 11th grade, never been on a stimulant. But there's so many articles and research out there that suggests that stimulant is more effective than neurofeedback, which Jeff was talking about. So who do we trust?
Right. Let me start with that last point and then kind of work my way back. So you know, yes, and why did that man trust you, Jeff? Because you were authentic with them, right? People we're designed to be able to tell when people are bullshitting us or when they're being authentic, and people sometimes mistake, you know, just be nice to people as a way to win their trust. Absolutely not, right? They won't trust you if you're fake. But if you talk to them directly and in a weird way, respectfully, right? Because you were being respectful by talking his language, and you figured that out quickly, and even were able to do it relatively quickly. That's when you can establish that rapport. And I don't think that gets taught very much, although I think people who are good clinicians of any stripe figure that out. But let me come back to the medicine reason, because here's where I think I am going to disagree with both you and Adriana too. So it may be easy at times to paint it as stimulants are bad or good, but they're neither. They are a tool that is appropriate and helpful in certain situations. And you know your kids better than I do, of course. I defer to you on what was appropriate in those situations. But I can tell you from having prescribed, you know, for my whole career, that I have seen situations in which stimulants have been very helpful. Now, is it ever the exact solution that I would have wished for in society? Probably not. So is ADHD a stimulant deficiency? Of course not, right? That would be nonsense. But let me give you a story that to me exposes how complicated and ultimately pragmatic we're being called to be. I used to work in a clinic in Upper Manhattan, sort of in the, you know, kind of a City College area, and I would see young children, typically young boys of color, who were brought in to this clinic by their parents because they were having trouble in school and often being disciplined and being left back or kicked out and so on. And the most common complaint was one of hyperactivity and inattention. And my first reaction, as somebody who you know, believes in the relationship and in psychosocial interventions and all, was, this is horrible, right? There is no medication that is going to treat this problem. This is a problem about our society, about classrooms, about the amount of money that was put into the schools, about the racial divide, around the history of racism. There were so many social reasons. Yet, and I thought all these things, right? And if I said to that mom, well, let me tell you about what's going on in Finland, right? She would have kicked me out. She would have stormed out of the office, and she should have, right? Because in my idealistic way, I was thinking about the way I wanted to design the world, and that wasn't going to help her at all, right? So did I talk to her about social interventions and meeting with the teacher? Absolutely. But sometimes I prescribed stimulants. And what I saw was that in the context of a wider way of addressing the system, those stimulants, I believe, were very helpful. And I do believe the data supports that. And I believe data supports that in certain situations, stimulants can help in behavior. And by the way, they can help get them out of a vicious cycle that often leads to other problematic behaviors, such as drug use and addiction. And later on, people think, oh, stimulants are going to make my kid addicted. It's actually, the evidence is the opposite. The evidence is that if you address the attentional issues early on, you can often prevent the addiction coming later for all sorts of complicated reasons. So to me, that's not a stimulants are good, everybody should be on stimulants. That to me is, it's a really complicated biopsychosocial problem. And at the end of the day, our idealism is just one piece of the consideration, but we're being asked to be practical. And if that can be helpful, right? You can take stimulants, doesn't mean you have to take them forever. It doesn't mean that everybody ignores everything else. I think that's our obligation. So let me just back up to one earlier point, and then I'll stop. You know, when we started by talking about the medical model, I sort of conceded that I think there are a lot of problems in the medical model, particularly when it's misused. But I wouldn't want to give the impression that I think the medical model should just be dispensed with or disregarded entirely. I think there is value in thinking systematically about how we talk about illnesses and how we then help people understand them and what they do with them. One of the things I like to say to patients is, remember, a diagnosis is just a tool. It's just a word. Don't give it the reality of saying that because you may have depression or anxiety, that is the totality of your experience. Think of it as something that you can use when it's helpful to you and not use when it's not. And I'll give you a classic illustration of this. I used to run an autism clinic in Manhattan, and people used to say to me sometimes, shouldn't we, that autism is so ridiculous, right? It's gone from 1 in thousands of people to 1 in 55. It's really a meaningless diagnosis. We should just dispense with that term entirely. And then, of course, I would think about the parents and the individuals who came to see me in the clinic who needed that word for a number of reasons. They needed it because it helped explain, even in a partial way, some of what they were going through. It helped them not feel as alone, again, if used appropriately, not if misused. And lastly, they needed a way to go back to the school system and say, my child needs more support. My child needs more resources, right? So for them, that word had enormous value. Did that make that word the totality of their experience? Of course not. And it should never become the reality. But can it be a helpful tool? Absolutely. So whenever this issue comes up of, do we use a diagnosis or not? Do we use a medical model or not? My answer is, well, what are we using it for? Why are we using it? And then getting into a conversation, a relationship about them.
I think my disagreement, I agree, all drugs, all medications have appropriate and inappropriate uses. And I think that's legal and illegal drugs. I think it doesn't matter. That's a cultural distinction, typically. At the same time, I think that most practitioners who medicate are not as careful as you are. And they're grossly overprescribed. I mean, I forget the percentage of people on antidepressants since 2000 or something, and the incidence of depression's skyrocketed since then. It's not as though it's containing any of that. But part of my disagreement is the idea of illness, is that we tend to label human experience as illness in a medical model. And I think, we can start to get into, autism. I did autism research when I first started out, and it's 1 out of 1,500 kids. My problem was that they made it into a spectrum that over-included tons of kids into that, where any kid who had any kind of developmental delay, any kind of quirkiness was put into that category. And then, we get services, but also carrying that label around. And I do have a problem, from old labeling theory of primary, secondary labeling theory, that labels can have really deleterious effects on people when they are labeled. It can help explain things, but I think my position is that we should label people's emotional and cognitive states rather than people. And that we can look at, I don't know, Adriana, if you want to put my alternative diagnostic system up, if you can share the screen. But, this is over, years of sort of thinking about this. I used to teach about personality disorders, for example, and about borderline personality and Cohen and Kernberg and all of this. And I found it was so pejorative. And do you really need that? And so, we kind of operate under, rather than these, anywhere from, I think Kraepelin, they had 2 diagnostic categories of manic depression and dementia praecox, up to DSM, I think it was 4, had over 500. They're now brought them down, but there are a lot of spectrum diagnoses. But there are all these distinct kind of diagnoses that don't have a lot of validity to them for the most part. And so the way that I tend to look at it is a more layered system that applies to human experience in general, so that we all quote, I always put normal in quotes because, we're normal some of the time, I guess, but there was a great thing I read about Freud where he said he treated in his career, he had one patient who had made it through all 5 psychosexual stages and theoretically would be normal, and he found it very boring. So, so there's normal anxiety and neurotic states. We all experience those in different circumstances, and depressive states. One of the things that struck me in terms of sort of the messaging that goes out in the media is that during the pandemic, there was an article, there were several articles like this, that said that 6 out of 10 young people are experiencing mental disorders, of anxiety disorders, depressive disorders, or OCD. My reaction was, what's going on with the other 4 who aren't? Because all of us were anxious. We had a worldwide deadly pandemic. We didn't know what was causing it or how you caught it. We were in lockdown. Everybody was depressed. You couldn't see your own parents. You couldn't see your friends for a good period of time. And how many were checking their groceries coming in and wiping them down and being, super vigilant? We all met criteria for an OCD diagnosis. And so, my point of it is that, and depressive states, the same thing, borderline states. All of us go into borderline states. I have my triggers will send me to 0 to 100. I'll be very black and white thinking. I think the difference between, hopefully, with myself and people that we work with is they have many more triggers and they have a harder time getting out of those states. And same with dissociative states. Dissociative states are an adaptation. All of these are adaptations. They're, we all dissociate in different degrees. Hopefully no one's dissociating right now, but we all do, when you're driving to work the same way every day. You don't remember the ride, you're dissociated. When we talk about DID, we're talking about someone who typically is sexually abused at a very young age, usually by a parent or a sibling. And it's very adaptive to dissociate and to leave, or create, even in the extreme cases, create another personality to handle it. Where it becomes less adaptive is as you grow up and you get triggered and you go into those dissociative states when it's not adaptive. So, we look at those things. Same with psychotic states. If, you feel your cell phone go off in your pocket and it's not there, you're having a hallucination. If we sleep deprived everybody for 4 or 5 days, we'd all be hallucinating and delusional. So again, these are sort of adaptations. Another example of this, well, let me say just that, so we tend to look at these things as we label the states people go into. We use DSM for insurance, and that's about it. So that's sort of the way that we look at this. And, it's similar to biological anthropologists who look at defensive systems as adaptations that activate in threatening situations, sort of adverse effects that cause psychological pain to minimize fitness loss. So anxiety, depression, PTSD may be adaptive responses to anxiety, or to adversity. And so I think it's a really different thing. It goes into treatment as well, because if you're giving someone an antidepressant, and that's a whole nother topic about how effective they are, because across the board, they've been no more effective than placebo. And I also will say that in some cases, I think they are effective with certain kinds of patients to get them out of bed or to get them to be able to sit with someone in therapy. But in most cases, they're no more effective than placebo, with a lot of very negative effects. But even if they were effective, what they typically do is they tend to numb a lot of the negative feelings. Does that interfere with the adaptive response of being able to sort of figure out what's going on if you're numbed to that experience? In other words, there was a great Twitter thing I had seen of a woman was talking to her husband's psychiatrist. Her husband had just died. And she was saying she felt very depressed. And the psychiatrist said, I can give you something for that. And the woman said, well, my husband just died. Shouldn't I feel sad and depressed? And the psychiatrist said, yes, but you shouldn't have to. I think our approach is that you do have to, that you need to experience some of these difficult, painful feelings in order to be able to manage them and come out of it. And I think sometimes a misuse of medication is when it short circuits that process.
All right, I want to give Dr. Gerber an opportunity to respond. I also want to, so Jeff, it sounds like you're saying just culturally, there is a notion that somehow we as a people should not be uncomfortable or be in distress. And that has impacted our treatment of clients and patients.
Definitely. And there's probably a whole nother talk about how capitalism and sort of current capitalism sort of supports those kinds of models as well, where, you know, we want to keep people productive and working, but that's a whole nother
Debate. Yes, Dr. Gerber.
Sure. I mean, you know, listen, this is another area I think where Jeff and I don't disagree, is that there are cultural imperatives that are, frankly, are dangerous. This idea that we should never suffer, or the other is that any treatment has to work very quickly, that we need a solution now. And I think there is a way in which, to some extent, you know, the love affair with pills, in whether they're, as you said, illegal or legal, is this fantasy that this is going to solve my problem, right? And any mental health professional, you know, can tell you that you know, many of these problems, most of these problems took many years, if not decades, for it to evolve. So the idea that it would suddenly disappear like that is contrary to even what I think it means to be a human. That said, I want to draw an important distinction, I think, which I don't think we've talked about so far, between milder illness and more severe or even moderate and severe illness. We all have experienced, you know, what's often referred to as the worried well, folks who are well functioning, relationships, jobs, and the way in which distress can be avoided or even pathologized as a way of avoiding dealing with the real world, whether it's loss or challenging relationships or internal conflicts. And I think what you're saying, Jeff, about that sort of questionable efficacy of the antidepressants and even the questionable use of them, absolutely. But of course, we've also all encountered people who are at a very different level of dysfunction and distress. The person who absolutely, you alluded to this, can't get out of bed, can't leave a hospital bed, wants to die so much that's the only thing they can think about. And every illness has some version of a very severe version. In fact, the concept of a narrow diagnosis falls apart most clearly in the very severe end of the spectrum, when people, you know, it doesn't matter, do they have depression or bipolar or even, you know, in some psychosis, because it all folds together. But for those individuals to say, and I know you would never do this, Jeff, but to say that's adaptive would be insulting, right? Because they're in so much distress that we need to find a way to break them out of this cycle. And by the way, that's not to say there aren't psychosocial aspects of their illness. I'm always been one to say that this notion that there's a psychological depression that's distinct from a biological depression, that's not true. There's no evidence to suggest there are these two different types of depression, right? There is depression, right? Or people, a symptom or a state of depression, as you correctly say, Jeff. And it has psychosocial aspects to it, and it has underlying biological vulnerability aspects to it. So if there's a way to intervene using medication, and I know it scares a lot of people, but using ECT, which in a certain population has enormously positive effects, I think it's not only important that we keep that option on the table, but I actually think we're obliged to offer our patients these options. There's a history of a field of compelling people to do things. And of course, that can be very problematic, particularly when you go back far in time. But we're not talking about that generally here. We're talking about giving people all of the options. And I think patients and their families need to be able to understand the different options and then to make decisions. And I think I worry when it can sound moralistic on the part of the treatment provider, which set of options is right for them. I know I have my preferences for me or for my family and so on, but that may not be the same, options that my patients choose. And I do want them to have full awareness of that. So that's, there is the goal that I think that I at least try to strive for.
And I agree with most of that. I think the problem, and I also think there's psychosocial interventions that aren't very effective, but are very supported by our system because they're short term and they're, it gets into a whole evidence-based thing we were talking about yesterday, that I think some short-term manualized therapies are not particularly effective or helpful, but they're pushed because they're cost effective for insurance reasons. And, I think that our culture, I mean, in terms of, and I agree with you that someone can't get out of bed, they're in vegetative kind of state of depression, they need something to help them get out there. I think we also agree that the thing that really is healing is the therapeutic relationship. And that's even, that's what placebo is in many ways, is it's not an inert thing. It's the expectation someone's giving you something to give you hope and to help you feel better has an effect in itself. And I think it's an effect in psychotherapy as well as clearly with antidepressants, where it's a very strong effect. But that the idea that, that I think the problem is that, and as you talked about when you first started about the kind of hierarchical thinking of not really respecting at the same level other mental health providers, for example, besides psychiatrists, that most will say that they do a biopsychosocial model. As I've said too, I think it should probably be a psychosocial biomodel in terms of where the priority might be. But in my experience in private practice for many, many years, I would see people for years doing dynamic therapy, and they would want to try an antidepressant. They'd go see a psychiatrist, and I'd give them my card and say, have them call me. I almost never got a call from anyone. This is someone they would just prescribe, and this is someone I had a lot of data for, though, I'd seen for years. So I think in theory, a lot of these things make a lot of sense. The other problem that we've discussed too is I think something like 90% of psychotropic meds are prescribed by non-psychiatrists. You can call your internist often and get an antidepressant or a benzo. And benzos are another whole category of a drug that's useful in very small circumstances, I think, and appropriate, but they're prescribed like all over the place. I think, I was reading about Naomi Judd, and the media narrative was she was killed by the disease of mental illness. But then you read what her experience was, and she was on multiple antidepressants with some really negative effects. She was switched from one to another. She was on multiple benzos and sleep meds, and was labeled treatment resistant by her psychiatrist, severely treatment resistant, but it turned out they'd never tried psychotherapy. So, again, it's hard to know what went wrong there, but to just say that it was mental illness that was her demise just seems simplistic and doesn't really take into account the treatment, because there is a lot of iatrogenic damage from medications. And, again, my biggest concern is all the non-psychiatric physicians who prescribe all of these very powerful medications without really knowing a lot about them, aside from pharmaceutical reps and that.
I want to get to one other question, but real quickly, if somebody can answer this for me. When Dr. Gerber, you're talking about just people having the options, how do we truly give people informed options when our culture supports and pushes interventions that are cost effective?
It's such an important question, and in a way, it's the question I think that unites us and should really unite the whole wider field, because we can be sure that the for-profit industries have many people figuring out how to market and how to shape the narrative. And I think one of the things I've seen in our field, whether it's psychiatrists or psychologists or social workers or psychoanalysts and CBT therapists, we tend to be a circular firing squad. We tend to, attack each other. And we're so busy attacking each other that meanwhile, the pharmaceutical industry and the insurance industry is out there kind of laughing and using us against each other in a way, which they do in all sorts of ways. So I think first of all, we have to unite. We have to agree that some of our differences, and I don't mean all of them, but I mean some of our differences. For example, the one that I've spent most of my career hearing about was the fight between cognitive behavioral therapy and psychoanalysis, right? And they would talk about each other with the greatest contempt. I had teachers who taught one and talked about how terrible the others and so on. And lo and behold, what I found is there are good therapists on both sides, and there are bad therapists on both sides. And surprise, surprise, right? There are patients who get better. Now, I think sometimes the reason people get better in psychoanalysis are things that maybe those people don't technically call psychoanalysis because they are more behavioral and cognitive. And there are things that make people better in cognitive behavioral therapy. They're actually more psychoanalytic. They just don't call it that. So there's a lot these things have in common. That's just one example, of where I think we have to sort of agree, maybe to disagree, and then say, how do we as a wider field really advocate for the need? Because at the end of the day, it's always going to, at least in the short term, cost more money to take these problems on. And we can argue, and I believe it's true, that in the long run, it saves society money. It saves society money in our prison system. It saves it in all sorts of other ways. It makes, it's actually, even from a capitalist perspective, not that that should be the be all end all, it's better for society, makes people more efficient if we treat them well. But those are longer term gains. And I don't think our capitalist system is set up, unfortunately, to see that. So we're going to actually have to beat them at their own game, which is we're going to have to win public opinion and get our leaders and politicians to understand these things in ways that will make them pass the laws to regulate. I mean, I'll give you one example of this. So as I imagine many people know, one of the achievements under the Obama administration was passing of the parity bill. And the parity bill basically says an insurance company, it is illegal for an insurance company to put in obstacles to mental health care that are fundamentally different than the kinds of conditions they put on medical care, non-mental health care, right? Seems kind of like a no-brainer, right? Well, turns out that all the major insurance companies are violating parity every single day. We see it all the time here at Silver Health, right? And the insurance company's getting away with it. Why are they getting away with it? Because first, it's really confusing, and you have to be really an attorney, and the people who help me understand this are attorneys, to understand the ways in which they're breaking the law. But second, you've got to convince the government to actually enforce the parity law, which they're not doing right now, because it's expensive. You have to actually hire lawyers, and you have to investigate the insurance company, and maybe you don't get the donation from the insurance industry or whatever. But that is going to take a concerted effort. And by the way, if the insurance companies have to pay for longer treatment and for better treatment, meaning people with more experience, and I don't mean more MDs or more PhDs, I just mean more treaters, right? The ratio of treaters to patients is low because of how little they pay in most institutions. It's higher where you can get adequate reimbursement or people can self-pay. So we've got to bring these things to light in a simple and clear enough way that the public as a whole can get angry about what's going on and see what the insurance company and the pharmaceutical industries are doing, and then essentially call for legislation that actually gets better care for people. To me, that's the pathway. Now, it's not easy. And listen, it's not what any of us went to school to do. I don't know how to do that stuff. But I think we have to find a way to get behind it. And fortunately, there are folks out there, who care about this and who know how to fight these battles. So I think that's a little bit of a challenge for us to get behind those kinds of funds.
I agree. But I think the challenge when we look at sort of neoliberalism, where it's deregulation and privatization and inclusive sort of mass wealth disparity, austerity budgets, and those all contribute to financial misery, mass hopelessness, anxiety, and then there's this belief in self-interest and competition, and rather than cooperation. And so, these kind of circular firing squads are created in all areas of our culture at this point. And the idea that, to cure people's ills, is to cure the individual, as opposed to look at the whole social systems. And society kind of gets a pass in that kind of view. And so, I think it's a little daunting, but it's the idea we really need kind of a paradigm shift. People who are homeless are depressed. It's not something going on in their brain. It's like there's life circumstances. And so, it becomes I think there needs to be a real paradigm shift in terms of how we look at human experience and problems in human experience, and move away from seeing it all as illness, would be my view.
I'm very excited about what you all are talking about, because I'm one about, we got to create a system that works, because the current system is not working in a way that is conducive for optimal health for all people. It is not equitable. So I like all of what you're talking about in terms of these macro level interventions, and creating a system that values people over money. But at the same time, as you said, Jeff, that is a daunting, and that is a far off intervention that we have to get behind. And I want to bring it back to what Dr. Gerber was saying too, in terms of the practical piece. How do we, on a micro level, while we're fighting the system, which absolutely has to happen, and this is my last question before we open it up to the audience, how do we create a different approach that understands clients in all their complexity, rather than relying on the unscientific stuff and that invalidates our experiences, and then that's culturally and gender biased system that we have right now? How do we create a system that is different? Because that's what we can do on an individual basis in terms of different organizations.
Yeah, I might. We're trying to do that at PCH, and trying to create a pathologizing system in which we all collaborate with different. We have psychiatrists, we have psychologists, we have social workers. We have all different levels, and I think Adriana, I'll have you sort of talk about what you're doing for a minute, in terms of trying to do it from sort of the inside out, of doing it from, hopefully, and then economically, we've been successful. So that can breed people trying to do a similar model. And I think it's trying to do it in a way from the inside out, because I think the other part is daunting, to try and create a paradigm shift in a culture.
I'll tell you the saving grace for all this for me, when I get too depressed about all these things, is I think about people as individuals. And it really goes back to something, Jeff, you emphasized early on, and the point we absolutely agree on, right? Human relationships are at the core. And the vast majority of humans, particularly the humans who go into this field of wanting to help people, genuinely want to help. And they use their relationship in order to do good. And so as frustrated as I am with our larger system, or systems, I should say, when I hear about the clinical work that individuals do, most of the time I feel good, because I know the therapists, and it's the therapists and psychiatrists and others at PCH and at Silver Hill. They come to work every day, not because they're the most high paid people in the world, not bad, but you know, but because they love helping people, and because they get to sit in a room with their patients and their families and use the power of their relationships to make people better. And even when the insurance company's not paying, or when technically it's time to go home, they stay and they go over and above. And I know the folks at PCH do the same, because they want to help people. And whether they call themselves psychoanalysts or DBT or CBT or whatever they call themselves, they do good. And even when they're nominally there to receive a medication, those good psychiatrists are doing a kind of therapy in those moments. So we talk about the placebo effect, right? You know, it's always funny to me that we call it placebo, because placebo makes it sound like it's somehow fake, but actually it's the relationship, right? And we're helping people in an extraordinary way, and we should be celebrating that and doing more of that. So that's what cheers me up. And it makes me think, Adriana, that even when we're not looking macro and thinking about solving all the world's ill, which is daunting, we're you know, one patient at a time, as they say, you know, we're actually helping protect an environment for good care. And you know, guys like Jeff and me and you that work, that lead institutions, our job is to protect our clinicians so that they can do the work, right? And so they don't have to worry about some of the things that we worry about, but that they have a place to go every day where they know they're going to be rewarded and protected to help people, and that's what keeps me going.
Let me add one more thing, and then we'll, you know, the therapy outcome research, which is really difficult to do, but they look at all different models. And the one common thread that comes through is the relationship, that good therapists do well in whatever model they use. And I always see, I think we all choose different models based on our own kind of view of human nature, but I think there are ways in to a relationship with people. And some people can use a less structured model to get in to understand someone. Some people need more structure for it, and there's more cognitive models and things like that. I don't think the model matters all that much if you have a really good therapist. And I think the good psychiatrists I know actually meet and talk to people. And I think that, as you said, placebo, I mean, Irving Kirsch, who talks about, you know, did 30 years of research, 50% of the response rate is due to placebo, which is reinstilling hope in people who are depressed, because depressed people are hopeless. So just the action of giving someone something helps them, even whether it works or not. And because that makes it work. And I think, you know, the way we look at psychiatry, and our psychiatry director and I've talked about this a lot, we both agree it's the relationship. And he spends a lot of time talking to people, and that we see the use of medication in our program as a way of, if we use it to enhance the relationship. If someone's having a hard time getting out of bed, they're having a hard time talking, or if they're responding to internal stimuli, they're going to get a low dose antipsychotic med, not for long, but to allow them to engage. And I think that's the key to most of this.
Thank you very much, gentlemen. And thank you, Jeff, for plugging my new program. It is called Divinely Restored Health and Wellness.com. You can check me out. But yes, it is in support and the vision, and inspired by PCH, is how do we bring this level of care to the most marginalized people in our community, for those who are uninsured and insured. And I'm trying to create a movement where it's about treatment for the people, by the people. And so donation driven, as well as Medi-Cal and everything else, so that people who are marginalized can get this quality of care. Now I'd like to open it up to questions from the audience. You can unmute yourself, or you can put your question in the chat. Let me check the chat. Richard commented, we need to stay modest and also evidence-based. The level of our knowledge is still primitive, but it is the best we have, and our patients are in great need of it. We do the best we can with what we have. You have had an excellent discussion of all of these issues. Anyone want to comment on the issue of evidence-based and the biases around evidence-based?
Sure, I'll start, and Andrew will chime in, I'm sure, on this. You know, I think evidence-based is a really good ideal to try and find. I think it's also been seized upon by insurance and as a marketing tool where they will pay for evidence-based treatments, which may not be the most effective, but then not pay for longer-term, more effective treatments that are harder. Well, they're not researched very well. And part of the problem, I mean, it also goes into academia, where in order to advance in academia, you need to get published. And so people tend to do very safe and shorter term kind of studies in order to compile publications, and are very reluctant to do like a long-term treatment study that may not turn out in a way where you're published. So there's a discouragement of really interesting research, in my view, in academia, and I was there for a certain number of years. But I think, like, some of the, for example, some of the antidepressant research over the ones that, mostly they're pharmaceutically funded studies, find effectiveness at 2 to 3 points on a Hamilton scale, which is statistically significant, but it's clinically insignificant. You can't, the client or the patient or the doctor can't tell the difference. Same thing with some of the manualized short-term cognitive therapies that they say are for depression. They get small increments, and there are no long-term follow-ups to a lot of these studies. So the evidence-based thing, I agree, in theory is a great idea. I don't know in practice that it's always the best distinguisher.
So first, I have to start by thanking Dr. Francis for being here. And by the way, when I say you should call me Andrew, I call him Dr. Francis because he's been a role model for me for much of my career. So for those who don't know, Rich Francis was the former president of Silver Health for many years, and really responsible for a lot of the hospital we have today. So I'm very grateful for him. But the other thing that if you don't know, you might not know, is we talk about the kinds of relationships that Jeff and I have been talking about. I mean, that is the core of who he is. And I hear the stories about Rich very frequently from my staff who've been here and overlapped with him about the way he is and has been with patients. So when I read the comment about evidence-based, I hear it through that lens, knowing this is somebody who loves that. And I'll speak for myself, and Rich, you can say if you agree with this. There have been times in our field where there were groups of practitioners, and at times those were psychiatrists and psychoanalysts, who held such a kind of authoritarian control around the types of treatments that were given, that it was actually very limiting to the field. There's a very famous case called the Osheroff case, where, and this happened to be a physician actually, who had a very severe depression. He was hospitalized at Chestnut Lodge, which is a hospital that's no longer in existence. And because of ideologic reasons, they decided not to give him medication because they thought he should have good psychoanalytic psychotherapy or psychoanalysis. And for over a year, he remained in a close to vegetative state where his life fell apart, because of this conviction. And finally, his family pulled him out, moved him to another hospital where he received medication, and he very quickly resolved. Now, I'm not saying that's the case in every, but there's a case where the opposite was true, that where a non-evidence-based conviction, near religious conviction about what you had to do led, I think, to really bad care. Now, I'll tell you two little notes. One is that he then sued and won that lawsuit. His family sued, won that lawsuit. Chestnut Lodge subsequently closed. But the other is the hospital he moved to was Silver Health, and that's in the public domain, so I get to say that. So we are not an ideologic place. We do what works. And I think what's good about evidence is that it's a systematic way of identifying what works. Now, can it be hijacked? Absolutely. Has it been hijacked? Absolutely, right? When the drug companies say, take my drug because it's evidence-based, those of us who believe in evidence cringe because we see it as a misuse. When the insurance companies say, well, we're not going to support that care because it's not evidence-based, they're lying, they're wrong, actually. And they're misusing a term as a way to exert power. But the problem is the baby in the bathwater again. we don't want to throw out the concept of evidence because it's being misused. We have to fight. And I do think, I do complain in my own field when people who know better aren't protesting more loudly when the term is misused. I'll give you one more example of this, even though it's a slight bit of a tangent. There's a publication in Fairfield County that is a kind of one of these throwaway coffee table things, and on the back cover, there's these pictures of brains, and they're MRI images, and there's a big title that says, come to our clinic, we will fix your brain. And people show it to me and they say, oh, look, Andrew, I know you like MRIs, right? And I say, that cover enrages me, right? I have gone to lots of places to try to show people how terrible that is. And it's not just because they're deceiving the public in that advertisement and using essentially a false claim that they can somehow use brain imaging to cure people, which they can't, because we have no way of doing that yet. But it's because it makes the rest of us who are hopeful for a future where science will be helpful, it disempowers us, because now you would be correct in saying this is nonsense. And now every time I see a brain image, I'm going to say it's nonsense. And I know people who say that. So I think it's our job to fight against the misuse of evidence-based, the misuse of brain imaging, and actually look to identify the places where it's actually valuable.
Thank you.
Just to add one more thing, I think that, we're looking at the science of all this. There's also a real art to doing client care and therapy. And I think sometimes that gets overlooked. I always think some of the best views of human experience have come through literature and art. And I think the best therapists I know are artists or writers or, of some kind. And so I think sometimes we lose that. And I think it's a really important piece.
And by just to make 100% clear, I totally agree with you, Jeff. And that's where the either or troubles me so much, because on any given day I may be using 90% art and 10% science. It doesn't mean we throw out the science. It may be different on a different day. And the idea of using them both for what they're good for is to me at least where we want to take the field.
Mm-hmm.
Thank you both. Dr. Francis, did Dr. Gerber represent you well?
He was very, very kind. I just really worry about all bullshit, including my own. I used to have a Japanese sign from the 1860s, a pharmaceutical sign in my office that basically said, this medication is good for ascites, it's good for this, it's good for that, it's good for everything. Basically, snake oil. And our field has done a lot of snake oil. So without science, I think we are on very, very shaky ground. I just wish that we had more science when it came to Alzheimer's, depression, addiction, my field that I have worked on for 50 years. I started the American Academy of Addiction Psychiatry. We've done a lot of research. We have more deaths now than we ever had. We're not making a major dent. So yeah, there's a lot of screwy things in our healthcare system, and the disparities in healthcare are enormous. I mean, what a rich person or poor person gets in this country is enormously different. To say we are all artists as well as scientists, definitely true. To say to stay modest and to just admit that we're going to do the best with what we have, and the relationship is important, but we can't just rely on the relationship. We also have to have skills, attitude, and knowledge base that stays up to date with the latest things. I was also saying to Andrew that the tone and everything that was said and everything Andrew said reminded me so much of my brother Al, who I don't speak that much anymore. My brother speaks out a lot, and he always looks for the bullshit in everything, including his own bullshit in the DSM. I'd say we all have to be skeptical of stuff.
Yeah. So in case people don't know, it's funny. Your brother may be more famous in some circles. You're more famous in my circle, Rich. But Al Francis was one of the authors of DSM-4, and in a really, what I thought, incredibly courageous way, came out and really talked about the problems in the DSM very vocally and in ways that were not particularly popular in our field at times. But I think he demonstrates the responsibility we all have to speak honestly about what we see.
And he's
And
sometimes
bravery.
wrong. He's sometimes wrong. But the things that Andrew said were all the things that he says right. So Andrew was able to pick out the wisdom of my brother's.
And I bought a copy at one point of Saving Normal for a number of our staff. So I've been very familiar with him as well.
Nice. Yes, well, he was very brave, so we appreciate his contribution to the field. We have a comment and a question. What I'm hearing is that there are really no universals. We have to look at all aspects of a person and their situation. The question is, can you comment on the dilemma for clinicians whose values are in line with taking insurance and on the ground don't want to be limited in what we do? How do we do it, and how long, and for how long?
I mean, let me just start by saying I admire that value and think that a core part of both PCH and Silver Hill is the notion that we too, in part, take insurance, and it's a very delicate balance because unfortunately, if we only took insurance, I think we couldn't do the kind of work we do, but we essentially can take insurance for part of our continuum of care, inpatient and outpatient. And we are actually in the process now of finding ways to take some insurance for residential. And we essentially use that to subsidize, and then there are other parts of the hospital that are private pay that we then use to subsidize it, because the challenge is, as you're alluding to, is if the rates are too low and if they try to control what you do, it starts to take the whole reason we went into the field away. And so, for me, and this is a personal decision for me, that notion of the sort of cross subsidy model, I sometimes call it the Robin Hood model, where you do some of both, and that's a way to gain some freedom. And when I see private patients, I will often do a sliding scale and lower their fee a great deal, and I can do that in part because I'm subsidizing it from another way. So that's one way to handle it. But the other, and I alluded to this earlier, is I think we have to fight back. And I think there are a growing number of organizations that are looking for ways to hold the insurance company accountable. And you can't do it yourself using their phone tree, right? I mean, that's what they really want, is to get so infuriated that you give up and never try. We can't go the direct route. You have to go through some of these organizations that are getting people together and fighting back. I'll give you one example of that is the Kennedy Forum, where Patrick Kennedy created, and he's been one of the major advocates for the class action lawsuits against the insurers for violating parity. And I think we need more support for those organizations.
And I think at PCH, we will do out of network, and we will help people with reimbursement. But the reason we don't take in network is mainly a clinical reason, is we don't want an insurance company board determining length of stay. And because we're not going to have somebody leave when their insurance runs out if we do that. And so what we do is, we're private pay, and we'll help people with reimbursement. If they're still in the middle of treatment and they've run out of money and the insurance isn't paying, we'll often scholarship people. I don't like to advertise that, but so and I did the same thing when I did private practice. I would just lower people's fees rather than deal with the insurance companies. So.
Right. Well, thank you for being change makers, both of you. And it sounds like we have some work to do as clinicians, as advocates for equity. And so thank you to Dr. Ball and Dr. Gerber for this very stimulating discussion. Again, if you are needing CE, please complete the evaluation that will be sent to you, if it has not been done so already, and send it back to ce@pchtreatment.com. We will get your evaluation out by Monday. Thank you all so very much.
Thanks, everybody. Thanks, Jeff. Thanks, Adriana.
Thank you.